Hey guys, I'm Tamari Mitchell, and this is my NG2 lab checkoff or video. All right, so we have our Laerdal patient with the face. This will serve as my 60 milliliter syringe because I didn't receive one. And then here is our NG2. All right, so we'll go ahead and get started. So first things first is I would check my patient history and make sure they didn't suffer or experience any nosebleeds. They had aspiration history, nasal polyps, chronic sinus infections, or to make sure they also didn't have any like oral, nasal, or sinus surgery, or any anticoagulant therapy. So in this case, my patient did not, so we can move further. So next thing I would do is make sure this is my correct patient, and with that, I would confirm with two identificators, which would be the birthday and the name of my patient. So this is our correct patient. Next thing we do is verify the orders, make sure that this is the patient we're putting the NG tube in, which it is, and provide my patient with privacy. And I also would place my supplies on a clean surface, which I did, and we'll pretend like my package was closed. So next thing I'll do is hand hygiene, and then I'll provide my patient with the rationale for why they're receiving this NG tube, and as well as if I were to be removing it, I would provide them with the rationale of why we're removing it. I also would inform them that they may experience some discomfort or gagging when inserting and removing the NG tube, and as well as asking my patient if they have any questions and getting verbal consent. So my patient says, yes, it's okay. So yeah, we're good. Alright, so next thing we would do, I would assess my patient and make sure he's not having any pain, nausea, or vomiting, which he is not. And as well as, next we will move on to positioning our patient and getting him in the right position. So what we'll do is put him in the high Fowlers when putting in an NG tube. I do not have a bed, so we'll just pretend like him sitting up, which is what a high Fowler position is. We'll just put him in high Fowler position this way. I'll raise the bed to my hips, which it already is, and I'll perform hand hygiene. So the next thing I would do is go ahead and prepare two strips of tapes, which will be 3 inches long each. I do not have any tape, so I'll just verbalize it. One strip will be a full strip, and the next strip will be what my professor calls fancy pants. It's when you strip the tape in the middle and it looks like little pants like this. So once we have those prepared and stuck to the surface, a clean surface, and waiting for us to use them, next thing we'll do is we'll go ahead and assess put on some clean gloves first. And then we'll move on to assessing our patient. So we'll take like a pen light and assess for any obstruction, nasal polyps, irritation to the mucosa, or a septal defect. And as I'm doing this, I can also ask my patient to confirm they haven't had any recent nosebleeds, nasal trauma, or any nasal surgery. And after that, he hasn't, and there's no signs of irritation, obstructions, or nasal polyps or any sort like that, we can move on to assessing my patient further and making sure that his nostrils are patent and assessing his gag reflex. So with the nostril patency, we just cover one nostril till our patient take a deep breath in and out. Then we do it with the other nostril, and then we ask if he have any trouble. He says no, and we're good. Next thing we do for the gag reflex is take a Q-tip and kind of rub or swab like the back of the mouth, and if they gag, then they have a gag reflex. Further into more assessment, we will auscultate the lungs and the bowel sounds with our stethoscope, and I would just note that there was clear lung sounds bilaterally, and as well as the bowel sounds were regular. So next we will move on to measuring our NG tube, so we can take it out the package. And how we measure it is tip to nose to earlobe and to the xiphoid process. So I'll do it on this side so you guys can see and get a general idea. I wouldn't have it touching the bed, but so you guys can see. So tip to nose, earlobe, and I will hold this. And then we don't really have a xiphoid process to compare to, so we'll just say it's here, and here is 40. So once we have that mark, what we could do is put tape on the NG tube so we can mark it. Like I said, I do not have tape, so we'll just memorize that it was 40. So let me just make sure I just keep my hand on it. Just so, but I won't remember. I won't forget that it's 40. So once we measured it, what we'll do is lube the first 4 inches of the NG tube. So we'll just pretend we have lube over here. Go ahead and lube those first 4 inches. And then I'm going to insert the NG tube slowly. But before I insert, I want to make sure that I take this little connector piece out and hook up that 16 milliliter syringe. And how we insert the NG tube is you do a back and toward the ear. So what I like to do is leave this out and ball the rest of it up in my hand. And that way I can like easily insert it. And we remember that our stop point is 40. If we had tape, then you would see the tape and you'll know, but I don't. So we'll go ahead and insert. And we'll kind of insert it like an inchworm. So I'll put it back and towards the ear. And then once I'm in, I would have my patient have a cup with a straw, and I would have him take sips, and every swallow, I would keep entering. So I would tell my patient, to go, make sure their chin is to their chest as well. Make sure your chin is to the chest, and then you go ahead and give your patient the cup of water, like I said, and insert with every swallow. So after the chin is to the chest, we just pretend, have patients like take a sip. Once they swallow, we insert, sip, swallow, insert, sip, swallow, insert, sip, swallow, insert, sip and swallow, insert, and then we're almost there. Sip, swallow, insert, and we have like one more. Sip, swallow, and insert. So now we're at the 40. So what we'll do is keep our hand on this tube so it's secured, and what we'll do is take our fancy pants tape first, because it serves as an anchor, and tape it. You would tape it along and secure the tube to the nose, and then we'll take that second piece for just extra securement and put it over the fancy pants, just so it's secured to the nose. So once that is secured to the nose and it's with the tape, and next thing we do to make sure that it is in place is we could auscultate the lungs, and as well as we would test the gastric fluid. So that's what this syringe is for. We would take the gastric content, it would come in this syringe, and we put it on a piece of paper and test the pH of it. And the next thing you do, which is up to the provider, if this was up also for use for feeding, then we would send it on an x-ray to make sure it's in the right position. Or another thing that's up to the verbalizer or provider is if they want us to return that gastric content that we took out the syringe, or discard. In this case, I would say discard, because I feel like putting it back is just disgusting, but that's just me. Next thing, after it's already secured with the tape, we would fasten the tube to the gown with like a safety pin and clamp the tube with the connector. So we'll just pretend like this is the connector and do like that. And so this will be our NG tube. This is what it looks like. All right. So next thing we'll do is move on to the removal of our NG tube. So same thing, we would come in, identify our patient, confirm the orders, provide a rationale for why we're removing it, and tell them they may experience some discomfort or gagging while removing it. And the next thing we'll do is we'll move on to removing it. So first thing we do is remove that tape, those 2 strips of tape we put on, and as well as detach the tube from the gown. So we'll take that safety pin and we'll remove it. And next thing we'll do is we will tell our patient to hold their breath as we withdraw the tube slowly, and after it's already out, we'll inspect that tube for any intactness. So we're just removing it and they're holding their breath, and we'll move it slowly and smoothly. And once it's out, we'll inspect for that intactness, which in this case we would not see any. So we can ball this up, throw that away. And next thing we do is remove our gloves and perform hand hygiene. And then after we do our hand hygiene, we will assess our patient for their comfort. And then we will put the side rails up. Then I'll perform hand hygiene again. And then I will put the bed in the lowest position, make sure it's locked, the call light is in reach, and perform hand hygiene again. And we will be done.